So by the end of this presentation, I hope that you'll be able to identify trends in opioid misuse at a national and state level, to compare commonly misused opioids with regards to pharmacology and potency, to explain pharmacology and clinical pearls of commonly abused non-opioid medications, to describe management strategies for patients presenting with an overdose due to potent synthetic opioids, and to discuss initiatives for management of the opioid epidemic at the national, state, and hospital level. So before I get started, I think it's really important to tease out some of the terminology associated with opioids. Does anyone know the difference between an opiate and a narcotic? Any thoughts? It can be. So an opiate is a naturally occurring alkaloid, and opioids refer to compounds that are derived from opiates, but the two terms are often used interchangeably. Whereas a narcotic is a substance that can relieve pain and can promote sleep. It doesn't necessarily have to be an opioid. And what about the difference between an opioid use disorder and addiction? Any thoughts? No? Okay. So an opioid use disorder is a diagnosis from the DSM-5. Patients have to meet certain criteria to be diagnosed, but it's based on a problematic pattern of opioid use that leads to a clinically significant impairment. Whereas addiction is a disease of brain reward and motivation, so it doesn't necessarily have to involve opioids. So diving into some of the history associated with the opioid epidemic and kind of how we got to where we are today. Throughout most of the 1900s, opioid medications were used for chronic pain. In 1987, Oxycontin was approved, which was the first formulation of an opioid product that was dosed every 12 hours instead of every 4 to 6 hours. In 1990, Analgesic was approved, which is the first patch formulation, and we still commonly use this today. In 1995, Oxycontin was approved, and at this time, the FDA believed that the controlled release formulation would actually result in less abuse potential because it was absorbed more slowly, so it wouldn't have an immediate rush or high. Also in 1995, Actique was approved, which is a form of fentanyl that comes as a lollipop. So when it was the first pain medication approved to treat cancer breakthrough pain, but it was approved with a restricted distribution program because of prevention of accidental exposure. So in the early 2000s is when reports of overdose and death from prescription opioids really began to rise, and Oxycontin was considered to be a large part of this problem. So as a result, there were changes added to Oxycontin to clarify its use. A black box warning was added for concerns of the possible for drug abuse and dependence. And there was an issue, the FDA issued a warning letter to the manufacturer to clarify misleading advertisements. So in 2010, an abuse deterrent form of Oxycontin was FDA approved. And in 2014, Evzio was approved, which was the first auto-injector designed to deliver a dose of Naloxone outside of the healthcare setting. In 2015, Narcan nasal spray was approved, which was the first FDA-approved nasal spray version of Naloxone. So this graph is one that many of you have probably seen before, and it kind of describes the time period that I was just talking about. So the early 2000s, when opioid overdoses really started to increase, to 2015, and you can really see the increase over the years of opioid overdose-associated deaths. So looking at some more recent data, this chart shows the difference in drug overdose deaths from 2015 to 2016. And although it's not complete, the United States showed an increase of 20% in drug overdose deaths from 2015 to 2016. Looking specifically at Virginia showed an increase of 38% in drug overdose deaths from 2015 to 2016. So this graph breaks down the different drug types and their associated increase in overdose deaths from 2015 to 2016. And again, focusing on Virginia, heroin deaths increased from 339 to 451. Natural and semi-synthetic opioids had an increase from 270 to 346. Synthetic opioids, excluding methadone, had an increase from 263 to 692 in 2016. And cocaine saw an increase from 168 to 263 overdose deaths in 2016. And that increase of 38% was pretty significant when compared to the rest of the country. So that brings me to my first assessment question. Which of the following drugs of abuse has seen the largest recent increase in overdose deaths in the state of Virginia? Is it A, carfentanil, B, heroin, C, synthetic opioids excluding methadone, or D, cocaine? C, yeah. Did that go? Okay. So now I wanted to move on to talking to some of the common drugs of abuse, if anyone's looking for some new pajamas. So opioids are classified as being naturally occurring, semi-synthetic, or synthetic compounds. So naturally occurring compounds are derived from the opium poppy, and examples of these are morphine or codeine. Simple chemical manipulations of these naturally occurring compounds lead to semi-synthetic compounds, such as buprenorphine or oxycodone. And then synthetic compounds have also been created. So some examples of these are fentanyl and the associated derivatives, and methadone. So opioids act on the opioid receptors. Opioid receptors are present within the CNS as well as throughout peripheral tissues. The receptors are normally stimulated by endogenous peptides that are produced in response to a noxious stimulation such as pain. And there are 3 different types of opioid receptors. Mu receptors, which are found primarily in the brainstem and medial thalamus. There are 2 types of mu receptors, mu1, which are responsible for analgesia and euphoria, and mu2, which are responsible for respiratory depression, dependence, sedation. There are also kappa receptors, which are found in the limbic and other diencephalic areas, the brainstem, and the spinal cord. And they're responsible for spinal analgesia, sedation, dyspnea, dependence, and respiratory depression as well. And then delta receptors are located largely in the brain, and their effects are not very well studied, but they're thought to be responsible for some psychomimetic and dysphoric effects. There are also sigma receptors, which are not considered opioid receptors, but they're the target sites for PCP and various analogs, and they're also thought to be responsible for psychomimetic effects. So I'm hoping that this will work. Quick little video to talk about the mechanism of action.
The influx of calcium ions causes the release of neurotransmitters into the synapse. Those neurotransmitters will float across the synapse and then bind with receptors on the postsynaptic neuron. This initiates a chain of events within the secondary neuron that further propagates the pain signal to the brain. There are specific opioid receptors on both the presynaptic and postsynaptic neuron. When an opioid compound attaches to a receptor on the presynaptic neuron, it decreases the amount of calcium ions that can enter the cell, ultimately decreasing the amount of excitatory neurotransmitters that are released into the synapse.
So in summary, opioid receptors are located on presynaptic terminals of nociceptive fibers, and when they're activated by an opioid agonist, voltage-dependent calcium channels are inhibited. So this leads to a decrease in cyclic AMP and blocks the release of pain neurotransmitters, resulting in analgesia. So the first of the compounds that I wanted to talk about is morphine. So morphine is a naturally occurring compound. It's derived from opium. And when looking at the structure of morphine, the tertiary nitrogen is really crucial to the analgesic effects of morphine. So if you were to make this nitrogen quaternary or change the methyl group, it really reduces its analgesic effects because it's not able to pass into the CNS. The hydroxyl groups at the 3 and 6 positions are also common in this class. And presence of a hydroxyl at the 6th position leads to a higher incidence of nausea and hallucinations. Modifications can also be made at these positions to create other compounds. So for example, codeine has a methyl substitution at the 3 position. So morphine has a lower lipid solubility when compared to other opioids, so it crosses the blood-brain barrier at a slower rate. So even after IV administration, peak analgesic effects are not achieved right away. The bioavailability of morphine is about 25%, has a pretty significant first-pass metabolism. And it's metabolized predominantly via glucuronidation to active metabolites that are excreted in the urine. Oxycodone is a semi-synthetic opioid. So in looking at its structure and comparing it to morphine, it's structurally different because of the O-methyl group at the 3 position and the ketone at the 6 position. So if you remember from the structure of morphine, the hydroxyl at the 6 position causes more hallucinogenic activity. So by replacing this with a ketone, oxycodone has less of this activity than morphine. Its equivalence is about half that compared to morphine, The plasma half-life is about 3 to 5 hours, and its oral bioavailability is much higher. It ranges anywhere from 60 to 87%. The two main metabolites of oxycodone are oxymorphone, which is also a potent analgesic, and noroxycodone, which is a weak analgesic. Moving on to synthetic opioids, fentanyl is a phenylpiperidine analgesic. It has an extremely high affinity for the mu receptor, so it's about 50 to 100 times more potent than morphine. It's highly lipophilic, so it crosses the blood-brain barrier at a much quicker rate. The half-life for equilibration between plasma and cerebrospinal fluid is about 5 minutes. Fentanyl undergoes an extensive hepatic metabolism and it's renally excreted. So there are many different derivatives of fentanyl. Some examples of these are alfentanil, acetylfentanyl, remifentanil. Remifentanil has a more rapid onset of analgesic action than fentanyl. The analgesic effects of remifentanil occur in about a minute to a minute and a half after IV administration. So another one of the derivatives of fentanyl that's been increasing in popularity lately is carfentanil. Carfentanil is about 100 times more potent than fentanyl. And one of the reasons that this has been in the news a lot lately is because of recent exposures involving heroin that's been cut with carfentanil. So there's actually a commercially available product of carfentanil, which I was unaware of. It's for veterinary use. And one of the earliest reported exposures of carfentanil was by a veterinarian who was trying to sedate an elk and was accidentally splashed in the eyes and mouth with carfentanil. He was extremely nauseated, sedated, and hypotensive, and he was actually given 100 milligrams of IM naltrexone that was also intended for the elk, and we'll talk about some management strategies a little bit later on. So the final one that I wanted to talk about is methadone. Methadone is a synthetic mu-opioid receptor agonist. It's also an antagonist of the NMDA receptor, which makes it potentially useful in severe neuropathic and opioid-resistant pain states. It's basic and lipophilic. It has a really high oral bioavailability, and it reaches peak concentrations in about 4 hours. It does have a really long and variable half-life, so the half-life can be anywhere from 15 to 120 hours. So moving on to some of the street drugs, heroin is a synthetic drug made from morphine by acetylation at the 3 and the 6 positions. After IV injection, the effects of heroin begin in a little less than a minute. It has a really high lipid solubility, so it crosses the blood-brain barrier very quickly. The effects of heroin wear off in about 3 to 5 hours, depending on the dose. And heroin can be a white or brown powder or a black sticky substance known as black tar heroin, and it kind of depends on where in the country you're located as to what the prevalent forms of heroin are in those areas. It often has additives like sugar, starch, or powdered milk, and these can have detrimental effects as well. And it's also frequently adulterated with synthetic opioids such as fentanyl and more recently carfentanil. Finally, the final street drug that I want to talk about is cocaine. So cocaine binds to the dopamine, serotonin, and norepinephrine transport proteins and prevents the reuptake of these neurotransmitters, which increases their concentrations in the synapse. So cocaine produces a dose-dependent increase in heart rate and blood pressure, increased arousal, and repeated doses may lead to involuntary motor activity and paranoia. The half-life in plasma is about 50 minutes, but intranasal and IV use results in a high that's of a much shorter duration. It can also be mixed with other additives like cornstarch, talcum powder, or stimulant drugs such as amphetamines. So this brings me to my next assessment question. What structural feature is necessary for the analgesic effects of morphine? Is it A, the tertiary nitrogen, B, the 3-hydroxyl, C, benzene ring, or D, 6-hydroxyl? Sean says A, so yes. It is A, the tertiary nitrogen. So I next wanted to talk about some commonly abused non-opioid medications. What kind of non-opioid medications can you think of that are often abused? Gabapentin. Benzos. What was that? Amphetamines, yeah. Any other ones? Dextromethorphan, yeah. So the first one I want to talk about are the gabapentinoids. Examples of these are gabapentin and pregabalin. They're analogs of GABA, and they bind to the alpha-2 delta subunit of voltage-gated calcium channels, which reduces calcium influx and subsequent neurotransmitter release. So gabapentin or Neurontin was FDA approved in 1993. It has indications for postherpetic neuralgia and epilepsy, and also additional neuropathic pain indications. Its absorption is a saturable absorption, so at doses of about 300 milligrams, the absorption is 68%, and at doses of 1,600 milligrams, the absorption is decreased to about 36%. So it does have a pretty high ceiling for how much you can give. It's not currently a controlled substance. However, within the past year, it does have to be reported to the Virginia PMP, so it is something that is starting to be monitored more frequently. Pregabalin or Lyrica was FDA approved in 2004. It has similar indications for neuropathic pain, neuralgia, seizures, fibromyalgia. It's about a 2.5-fold greater potency, a quicker absorption, and a higher bioavailability than gabapentin, and this one is a Schedule V substance. So why are these appealing to drug users? Their mechanism of abuse is not fully understood. It doesn't directly bind to GABA receptors, but it's thought to exert some GABA mimetic properties. And many GABA modulating drugs, such as benzos, do possess a known abuse potential. The dosages for abuse are also not very well known. They can range, case reports have shown them ranging from anywhere from 3,600 up to 7,200 milligrams per day. And they can, users can experience symptoms such as delirium, sedation, confusion, fatigue. So dextromethorphan is the next non-opioid that I wanted to talk about. It's known on the streets as robo-tripping or skittling. It's commercially available as a cough suppressant. So typical antitussive doses are 15 to 30 milligrams 3 to 4 times a day. But at large doses, the metabolite of dextromethorphan blocks NMDA receptors, which produces dissociative effects similar to those of ketamine. So you can see from this chart the ranges of effects with the increasing doses. So at doses of 2 to 500 milligrams, you can get visual sensations, closed eye hallucinations. At higher doses of 500 to 1,000 milligrams, altered consciousness, mania, panic, and then at doses of greater than 1,000 milligrams, hallucinations or complete dissociation. And just to kind of put in perspective how much that actually is, a standard bottle of Robitussin DM, 10 mLs contains 20 milligrams of dextromethorphan. So in a 120 ml bottle, you're only getting about 240 milligrams of dextromethorphan. Coracetin HBP is actually commonly used in people who want to take large quantities of dextromethorphan because the tablets have the highest amount of dextromethorphan per tablet. So one tablet of coracetin HBP has about 30 milligrams of dextromethorphan. And then another important thing to think about with this in overdose scenarios is the risk of serotonin syndrome if patients are also on serotonergic medications. So why is this appealing to drug users? It's really easily accessible. You do have to show your driver's license, so you have to be 18 in order to buy dextromethorphan, but it's not like Sudafed where you scan your driver's license and it tracks it. So you can easily get a high quantity of dextromethorphan. There's also a lot of information online. Just in my research trying to learn about this, I found a lot of information about how to abuse dextromethorphan. The next one that I wanted to talk about is loperamide, which is known on the streets as LOPE. It's a phenylpiperidine opioid derivative that's structurally related to diphenoxylate or haloperidol. So it binds to opioid receptors in the mesenteric plexi of the enteric wall, which inhibits the release of acetylcholine and prostaglandins, thereby reducing peristalsis and increasing intestinal transit time. So it's used in the treatment of acute and chronic diarrhea. The usual dosage of loperamide is 4 to 8 milligrams per day. So you can see since 1985, there have been 54 case reports published about loperamide overdoses, with 33 of those being from 2014 to 2016. So this is definitely something that's newer in popularity. Case reports have shown up to 400 milligrams being ingested. So if the normal dose is 4 to 8 milligrams per day, those who are overdosing on it are taking up to 400 milligrams, which is up to 200 capsules. And so what users will do is they'll put all the capsules in a blender and make a smoothie and drink it. In overdose situations, you can have CNS toxicities like meiosis, CNS depression, respiratory depression, and then life-threatening cardiac arrhythmias such as QTc prolongation. So why is this one appealing to drug users? Again, it's really easily accessible. This one is not monitored at all. There's no age restrictions. You don't have to show your driver's license. And it's not detected in routine urine drug screenings for opioids, but you can do a blood sample to test for concentrations in the blood. So that brings us to question number 3. We have PE, who's unable to get his hands on his normal supply of cocaine. He's heard of this new thing called Skittles that he wants to try, and he takes what would be the equivalent of 750 milligrams of dextromethorphan. What sort of effects would you expect to see? Altered consciousness, delayed reaction time, visual disturbances, partial dissociation, or all of the above? All of the above, yes. So I wanted to move on to talking about some overdose management strategies. So if you were to encounter someone with an overdose, no matter the setting, supportive care would be the first step in managing this patient. So identifying immediate measures to stabilize and prevent deterioration of the patient, assessing their vital signs, respiratory rate, mental status, and any cardiac changes. And then determining the drug of abuse. How often do you think we actually know the drug of abuse in an overdose situation? Yeah, so it could be helpful if we knew, but for the most part, if they're having respiratory depression, we're going to give them naloxone. So naloxone is as a competitive mu-opioid receptor antagonist, it reverses signs of opioid intoxication. So thinking back about the structure of morphine from earlier in the presentation, the most common structural substitution of naloxone is this larger moiety on the nitrogen group. Naloxone has a low oral bioavailability. It has a very extensive first-pass metabolism, so it's not effective orally. It can be given sub-Q, IM, IV, or intranasally. And the route that you would choose would obviously depend on what sort of setting you're actually in. So in an overdose situation, you would give a patient a dose of naloxone and monitor them for any changes in respiratory and mental status. Because it has a short duration of action, if the patients are not responding, you can give another dose typically in 2 to 3 minutes. And if they're still not responding after multiple doses, they'd likely need to be intubated. So knowing what we now know about carfentanil and its potency, how do you think we would manage a carfentanil overdose? Do you think they would require more naloxone because of the higher binding affinity? Potentially, but we're probably still going to start at the same initial doses and increase like we would even if we didn't know what the drug of abuse was. If they were requiring additional doses, we may start them on a naloxone infusion, but again, if they're not responding, they would likely need to be intubated. And what about loperamide? How do you think we would manage a loperamide overdose? So kind of again, if they're having respiratory depression, they're going to get naloxone. But what we're concerned about in a loperamide overdose is the potential for cardiotoxicity. So we would want to be monitoring for that as well. So patients who are taking high doses of chronic opioids can also receive prescriptions for naloxone as a rescue medication in case of emergencies as an outpatient. So a risk benefit should be made in patients who are getting greater than 50 MMEs per day, especially if they're on some sort of concurrent benzodiazepine or other risky drug, then they should potentially get a prescription for naloxone. And those who are receiving greater than 120 MMEs per day should also receive a concomitant prescription for naloxone. So in the outpatient setting, they're commonly going to receive the intranasal formulation. So examples of this is Narcan. The dose is 4 milligrams as a single dose in one nostril. Evzio is also available, but it's less commonly used just because it's expensive. But the dosing for the IM is either 0.4 or 0.2 milligrams as a single dose. And then IV is less likely to be used in an outpatient setting. But in the setting that we would use IV naloxone, we would dilute the 0.4 milligrams in 9 mLs and administer 0.04 milligrams, so 1 ml increments until a change in alertness is observed. So moving on to the final assessment question. During one of his drug raids, JP finds someone with altered mental status, constricted pupils, respiratory rate of 8, a heart rate of 64, and it's determined that this patient may have used heroin that was laced with carfentanil. What should be given to this patient to manage his overdose? So we're out in the community in this situation. Naloxone 2 milligram IV bolus, Narcan 4 milligram intranasally, Evzio 4 milligram IM, or naloxone 0.04 milligrams IV. I heard B, yeah. Out in the community, we would likely use intranasally as the first option. So finally, we're going to discuss some of the current initiatives that are in place to help combat the opioid epidemic. So on October 26, 2017, the opioid crisis was declared a public health emergency by President Trump. And so this designation of a public health crisis allowed for some federal grant money to be shifted for use to combat opioid abuse. So it permitted the hiring of specialists to tackle the crisis, expanded the use of telemedicine services to treat people in rural areas who may not have access to health care. And these are all things that are now coming with declaring this a public health emergency. Over the summer, CVS put out a response to their response to the opioid epidemic. So this isn't currently in place. It will be going in place in February 2018. But their kind of thought behind this was that to prevent the development of opioid use disorder by reducing unnecessary exposure to prescription opioids. And some of their restrictions that are going to be going into place, they'll be limiting opioid prescriptions to a 7-day supply for certain situations, limiting the daily dose of opioids dispensed based on their strength, and then requiring the use of immediate release formulations before extended release. So this largely does line up with the CDC guidelines for prescribing opioids for chronic pain management, and it does exclude patients who are in active cancer treatment or palliative care. But CVS is the first major chain pharmacy to put restrictions into place. So what do you all think about this? Just like general thoughts about CVS restricting.
It's kind of weird that they're like making the decision for the physician.
Right.
And some patients might be on like really high doses, something that should be managed by their pain clinic, not the pharmacy.
Right. And that might encourage people to look elsewhere for their opioids, be it another pharmacy, or if they're not able to get it from another pharmacy, potentially the streets. Or, yeah, so it'll be really interesting to kind of see the downstream effects of when this does go into place, what sort of happens with all of this. So on November 21st, 2016, so about a year ago, the opioid addiction crisis was declared a public health emergency in the state of Virginia, and this declaration came in response to the growing number of overdose deaths that were attributed to opioid use and the fact that carfentanil had made its way to Virginia. And so because of this, there was a standing order placed for naloxone for pharmacists to be able to administer naloxone in overdose situations as appropriate. So here in Virginia, we have the Revive Opioid Overdose and Naloxone Education Program, which provides training on how to recognize and respond to an opioid overdose emergency with the administration of naloxone. And this is an effort led by the Virginia Department of Behavioral Health and Developmental Services and the Virginia Department of Health. So there are two types of trainings for Revive. There's lay rescuer training, which teaches people how to understand opioids, understand opioid overdoses, and how to respond to an opioid overdose emergency with the administration of naloxone. And then lay rescuer training of trainers. So a little plug for Michelle McCarthy. If anyone is interested, she will be offering a Revive training on December 13th, and it is CE accredited. So more information will be forthcoming on that. Here in Charlottesville, the Thomas Jefferson Health Department started offering free naloxone for people. So you can actually, community members can actually go to local health departments and pick up naloxone for free. And they do have to go through the Revive training program before they're able to get this. So in October, there was a summit here at UVA where experts came together to discuss the opioid crisis in Virginia. And their approach to combat the opioid epidemic included increasing treatment capacity, reducing the number of pills prescribed that fuel addiction, and thinking about how to change the culture around using drugs. So some of the initiatives that are in the works here at UVA, there's a collaborative effort with palliative care, pharmacy informatics, outpatient pharmacy, Epic, to develop outpatient smart sets and order panels for chronic opioid prescribing. So this is specifically targeting the primary care clinics, but it will allow for indications to be added to orders for opioids, kind of like we see for antibiotics, to determine when opioids are being prescribed for inappropriate indications. There will also be an MEDD calculator that displays in the Epic outpatient encounter that can flag for the need for an additional naloxone prescription or if patients are receiving any other high-risk medications. Another effort in the works here at UVA is focusing on opioid sparing techniques. So palliative care is looking at grant money to study opioid sparing measures in cancer patients. And a large focus of this effort will be to use interventional therapies earlier and to look at safe and non-pharmacologic options when possible. So this is currently waiting on grant approval. And then a final initiative here at UVA, there's a focus on expansion or development of multidisciplinary clinics related to pain and palliative care, so incorporating pharmacy, nurse practitioners, and the hope for these clinics is to try to touch any area of the hospital or outpatient clinics that order or prescribe opioids. So when looking at post-op opioid management and outpatient surgery, collaborative efforts are trying to develop easy-to-navigate smart sets that are safe and include opioid-sparing options when appropriate. So more information will be forthcoming on that as well. And with that, I will take any questions or thoughts. Yes.
I guess any reports on for where it's a requirement to prescribe naloxone is over the 50 or greater, but in pediatric patients, it's more rare that they're on that much, but for weight-based, they may be on a really large amount.
Right.
Did you see any discussions of it being not just a flat milligram amount, but a milligram per kilo amount?
I did not, but that is a really interesting thing to look at. It would make sense based on a milligram per kilo in pediatric populations that they might also require naloxone, but I didn't specifically look into that. Yeah. Anybody else? All right. Thank you guys for coming. Happy Thanksgiving.